Should we get started? Amy, I think you were going to lead us off.
Yep, great, thank you. Hopefully my internet is okay. And the last thing I said, it was a little unstable, so just flag me down if I start cutting out. So I'm very excited to be here for this very important topic and to celebrate Disability Pride Month with all of you. I'm Amy Scribner, the Chief Health Officer at Health Plan of San Mateo. This year marks the 32nd anniversary of the passing of the Americans with Disabilities Act. It actually happened on July 26th, which was yesterday, but in 1990, which granted rights and protections for people with disabilities and launched the celebration of Disability Pride Month. As you all know, disabilities can be visible or invisible, and a disability is just one part of a person's identity. There's much intersectionality as people are multidimensional. While we've come a long way since 1990, we still have a long way to go. Although we highlight disability pride during the month of July, HPSM is dedicated to promoting inclusivity and continuously improving accessibility to healthcare services for individuals with disabilities. I'm glad you all have joined us today and look forward to partnering to bring awareness and acceptance for HPSM members with disabilities. Now I'll turn it over to Taylor, who will start the presentation. Thanks.
Thanks, Amy. Yeah, so I'm Taylor, and I am a population health specialist here at HPSM. Very excited to be here today and to be discussing Disability Pride Month with you all. And so I just want to thank you all for taking the time out of your very busy schedules as providers to join this conversation. And so I wanted to start kind of by acknowledging that this conversation may elicit difficult and sensitive topics regarding our biases and the structural barriers that members with disabilities often face. I ask for everyone to approach this conversation with an open mind and compassion for everyone here. My objectives today are to discuss HPSM's population of members with disabilities and offer resources on current programs and services that we have in place for these members. I also hope that we can facilitate a great conversation about ways HPSM, our patients, and our providers can help promote inclusion and accessibility in healthcare. So I'm going to start by giving an overview of HPSM's resources before handing it over to our wonderful guest speakers to speak further on disability inclusion in the healthcare system. So I want to give a brief background of the history of Disability Pride Month and why we're kind of here today. I know Amy gave a great introduction, but once again, Disability Pride Month is celebrated every July to commemorate the passage of the Americans with Disability Act in July of 1990. And the term disability pride is kind of used. The term disability pride is kind of used to signify acceptance and honoring of each person's uniqueness as a natural and beautiful part of our human diversity. And so this month seeks to celebrate the tremendous work disability advocates, allies, and others have done to celebrate and reclaim the visibility of people with disabilities in public spaces. I see a hand up. Is everything all right?
No, I don't see your presentation at all. I don't know if you have a presentation up at this point.
Scott, can you see my presentation?
We can see it internally. Can someone else, thanks for flagging this, Jennifer. Can anybody else who is not part of HPSM say whether or not they can see the presentation?
Yeah, I could see it. I could see it.
Jennifer,
I'll just listen then. It's fine.
Yeah, I might recommend just trying to restart, Jennifer.
Okay.
And we'll, of course, post the slides after, too.
Thanks.
Thanks for flagging that. Yeah, so the Disability Pride flag is shown here on the right, the black flag, and each color is meant to represent a different aspect of disability or functional impairment. So, for example, the blue lines are meant to represent mental illness, and the diagonal lines are meant to represent how individuals with disabilities must navigate barriers in their daily life with creativity. So what is considered a disability and what do we mean when we're using the term disability? I know there's many different definitions out there and they kind of vary by health plan versus our broader understanding versus what's in policy. So for us, the term disability is used to refer to any condition of the body or mind that limits an individual's ability to do certain physical or mental tasks and how you interact with the world. I also want to acknowledge once again that understanding disability can be complex, and the term members with disabilities encompasses a really large and diverse community of individuals, all with unique experiences. So some people with disabilities may have hidden disabilities, and one person's experience may be very different from another person with the same disability diagnosis. So that kind of brings us to our understanding of HPSM's members with disability population. And so the following demographic information that I'm going to be showing was compiled using our member data sources, along with member aid codes, which is the reason that members qualified for health coverage. And this is how we get the greatest sense that we can of the care needs and experiences of our members with disabilities right now. So demographically, about 6% of HPSM's membership, or about 9,000 members, are people with disabilities. So historically, in our healthcare system and in managed care more broadly, members with disabilities have been lumped together using the term SBD, and this is referred to seniors and persons with disabilities. However, it's really important for this topic and also for future conversations that we assess these groups separately, because the care experience of people with disabilities is often very different from that of older adults, which I'm sure we all know. And in fact, the majority of members with disabilities are between the ages of 22 and 64 in our membership, and only about 16% of our members with disabilities are over the age of 65. So while there is some overlap between older adults and people with disabilities, there are also separate populations that have very distinct differences and have different care experiences, both within them and between groups. And so as far as our race and language preference for this population, our membership of people with disabilities is more predominantly Caucasian than the general HPSM population, and you can see that here in the left graph. And then we know that our general HPSM member population is more predominantly Hispanic. And so similar to the general population, the majority of people with disabilities prefer English, followed by Spanish. And so we can see that here on the right graph. And then it's also worth mentioning that about 50 or 60 of our members prefer American Sign Language interpretation as well. So that brings us kind of to the different types of disabilities that people within our membership have. And so this table helps us understand those. And I want to acknowledge, again, this data is not perfect, but we can see that the largest subgroup of our members with disabilities is those with behavioral and mental health related concerns and those with developmental disabilities. So behavioral and mental health disabilities include things like anxiety disorder, major depression, bipolar, and schizophrenia. And then developmental disorders include things like cerebral palsy, brain injuries, and Down syndrome. So as far as the health experiences of those with disabilities, we see some key differences within the members with disability population when compared to the general population. Our population of members with disabilities experiences a high burden of chronic conditions. And so you can see that here. We see the incidence of chronic conditions and co-occurring chronic conditions is high based on these tables here. And we see that we also have high rates of essential hypertension, diabetes, and obesity within this population. And then additionally, our members with disabilities are disproportionately represented among behavioral health utilizers and SMI diagnosis, or serious and mental illness. And so this chronic condition burden is helpful to know because it helps HPSM and hopefully our providers understand the need for comprehensive care coordination and holistic care for these members. And while this data can be helpful, as I just mentioned, it's important to acknowledge that each patient is ultimately the expert on their experience living with a disability. And we acknowledge that we need to facilitate more meaningful conversations with these members about their experience with chronic conditions and mental health concerns. And that, of course, involves active listening and continuous learning. It's really our jobs as healthcare professionals and managed care staff to continue challenging our own biases about living with disability while meeting each member where they are. And again, this information will be shared out later. So if you don't get the chance to look more in depth in the slides, you will get a chance to see it later. So as far as the health gaps and disparities that we see in this population, I mentioned a few already, but the three that we're really trying to target as a health plan in the next coming year are the following. One, members with disabilities are significantly less likely to receive cervical cancer and breast cancer screenings. Two, people with disabilities are more likely to report discrimination and lack of access in affecting their healthcare experience. And then three, members with disabilities experience a disproportionate burden of chronic conditions and are more likely to experience social isolation and other SDOH related factors. And so all of these care gaps have brought us to further developing our understanding as a health plan and building out some resources for our providers and for our members to help facilitate care coordination and also make people aware of the options they have available for them as an HPSM member. And so I'm going to be talking about a few of those programs and resources we have. They're much more extensive than I'll be able to get into today. And I want to acknowledge that a lot of this work is ongoing. And so while we have developed out these new resources in the last few months, there's more work to be done, and I'll kind of highlight that as well. So for starters, we have the People with Disability Health Tips page. This just went live about 2 weeks ago, and this includes information on disability advocacy, health tips, and patient resources. And this also has a guide to all of the services that we have available for people with disabilities, and then how a member or provider can best refer each person into the care and services that they need. We also have our older adults and people with disability provider webpage, and so this includes more detailed information about our membership as a whole, demographic profiles, and a program service guide, again with more referral information. And we also include some tips for person-centered language and some checklists for serving these members as well. And so this is also newly live as of last week, thanks in part to a lot of work on HPSM's marketing team as well as population health team. So this is really exciting. We hope that this will be kind of the center of all things older adult and persons with disabilities as far as a provider standpoint. And so we're always open to hearing more about what providers may need more of or what other resources might be helpful. And then finally, as I mentioned, we have a lot of ongoing and upcoming work that we hope to further develop. Some of this work includes reinforcing pathways to refer members with disabilities into different programs, and then launching additional program pilots to address health disparities affecting this population. And so a lot of this is ongoing, as I said, but we're hoping to launch some additional programming for preventive screenings in the next year. And then finally, for the interest of time, I'm not going to touch on these discussion questions yet. I'm going to hand it over to our guest speakers shortly, but I just want everyone to keep in mind how we can all contribute to providing person-centered care and promoting inclusion for our members with disabilities, and also how HPSM can better support our members with disabilities in their healthcare experiences. So if you have any questions and comments, and if we don't get the chance to hear them at the end, you can always email populationhealth@hpsm.org. We're really interested in what our providers have to say about the disability, their experience working with members with disabilities, and other resources that you might need. And I'm now going to be introducing our guest speakers. I'm very excited to hear them speak. So we have Jennifer Drezen and Melissa Crisp Cooper. So Jennifer Drezen is the Senior Director of Programming at the ARC of San Francisco, and she directs extensive programming aimed at transforming the lives of individuals with developmental disabilities and promoting lifelong learning and independence. So she's joined by Melissa Crisp Cooper, who is a health and disability advocate as well as consultant, who has used her voice and her amazing writing to contribute to her expertise on advancing the health and independence of individuals living with disabilities. So Jennifer and Melissa, please take it away. I'll stop sharing.
Hi, everyone. We're just going to get set up here with our PowerPoint presentation. And Melissa's going to start us off.
What people with disabilities wish their doctors knew, the basics. Thanks for letting me speak to you today. A few years ago, I helped run discussion groups for the Office of Developmental Primary Care at UCSF. We spoke with a group of advocates with disabilities and chronic health conditions. We held separate groups for their care partners and supporters. Our goal was to learn what clinicians could do to help improve their experiences with the healthcare system. I would like to amplify the following suggestions from this group, others with disabilities, and my own experiences. The link to the white paper based on these discussion groups is included in the slides. First and foremost, patients with disabilities ask you not to make assumptions based on how they look, communicate, move, or on perceived notions about their specific disability. Every person with a disability has had a unique life experience. Most have adapted to their bodies. Ask questions about their life, strengths, goals, and abilities. You might discover they have many of the same hopes, dreams, and fears as their non-disabled peers. Their lives also include many intersections and cultural identities. They are not only disabled. They are spouses, children, parents, siblings, friends, professionals, students, artists, the list is endless. Doctors typically see patients with disabilities when they are sick, in pain, or during an uncomfortable procedure. Like all patients, these situations don't present accurate representations of their personalities or daily lives. Be careful about writing observations in medical records. These observations can negatively influence future medical professionals. Healthcare providers can sometimes use documents called health passports to learn more about individual patients with disabilities. We will discuss health passports in a few minutes. Like all patients, those with disabilities get sick. Not every medical condition has a direct connection to a disability, so don't forget to prescribe all the standard age and gender health screenings and symptom-appropriate tests. Other times, conditions may be connected to a disability. Even non-progressive disabilities may affect an aging body differently from a peer with a non-disabled body. Every body is unique. Some people with disabilities have stronger receptive communication abilities. This means they can understand your words even if they can't articulate verbal responses in typical ways. Like all patients, those with communication disabilities need to be included in conversations and decisions about their health. Talk directly to the patient. Ask them how they best communicate and how you can be a good conversation partner. When necessary, use plain language descriptions and visual aids. They might also benefit from either longer appointments or multiple appointments, depending on the individual and situation. Some people with disabilities may bring supporters to medical appointments. These supporters can help with physical tasks, communication, or provide useful information and observations. Just remember to direct questions and comments about their health and bodies to the patient. People in the disability community often use the mantra "nothing about us without us." Many patients want an active role in deciding what happens to their bodies. Supporters can also help people with disabilities understand medical information and weigh their choices. We will cover something called supported healthcare decision-making a little later in the talk. Other people with disabilities may choose to attend medical appointments alone. Much of the same advice still applies. Talk directly to the patient. Ask if they need assistance with tasks such as completing paperwork, undressing, or getting onto the exam table. You may also check for understanding and ability to perform tasks after a particular appointment. For example, you could respectfully ask a patient to repeat back important information or ask if they need support to schedule or attend an appointment for lab work. After an appointment, more follow-up and check-ins may be needed to make sure all questions have been answered and tasks were successfully accomplished. Health passport. Health passports can serve as part of a quick and useful initial introduction to a patient with a disability. These documents are written in plain language and are user-friendly for patients, their supporters, and clinicians. They give medical teams critical information about the wants, needs, communication preferences, and a brief medical history of the patient. Other information included in a health passport will help the team develop a more complete picture of the patient as a person. As medical professionals, you can promote the use of health passports. Encourage the actual patient with the disability to provide as much input as possible when filling out the form. Find a way to include these documents in the patient's medical records. Supported healthcare decision-making. Supported healthcare decision-making is an emerging concept gaining in use and popularity. It allows adults with disabilities to name one or more trusted supporters to help them understand and communicate medical information so they can be involved in their own care. It is based on the idea that people with disabilities should be able to receive the help they need while still maintaining some control over their lives. Supporters offer the individual an agreed-upon amount of tailored assistance. The person still has a say in decisions about their health care. With the person's consent, a supporter can assist them with a variety of tasks such as communicating with doctors, following treatment plans, understanding procedures, or maintaining a healthy lifestyle. Supported healthcare decision-making agreements. Sometimes people with disabilities want to define the types of support they need and who provides the support. They have developed supported healthcare decision-making agreements. The agreements can be formal or informal. They are completely voluntary and optional. Even though California does not yet have legislation concerning these agreements, when combined with other types of documentation, the agreements may reduce the need for conservatorship and guardianship, which transfer the total responsibility to make decisions to another person. Supported healthcare decision-making is much simpler to implement and easier to modify as needed. They can also ensure the person has support even when a primary supporter is unable to fulfill this role.
Okay, I'm going to pick it up here with advanced directives. So another way to include patients with disabilities in the decisions about their health is having them complete an advanced directive so that they can spell out their decisions about end-of-life care ahead of time. Pictured here is the California Advanced Healthcare Directive, and we have a link to that in our sources. Advanced directives communicate someone's wishes to family, friends, and healthcare professionals and can help avoid confusion later. Although we may usually think of only older or terminally ill adults completing these forms, any adult can choose to have one on file with their healthcare provider. As we've seen during the pandemic, unexpected health crises do occur, and having one's wishes known may protect against decisions being made about the quality of a person's life based upon their disability, which unfortunately we know has happened over the past couple of years. There are adapted advanced directive forms for people with developmental disabilities, including Thinking Ahead, which is a free resource, and again, pictured here, and there is also a link in the sources for this. The Coalition for Compassionate Care of California created this guide that enables people with developmental disabilities to advocate for themselves and stay in control of their lives through the very end. This document contains words, symbols, and pictures that facilitate discussion with and decision-making by persons with developmental disabilities regarding their values, goals, and treatment preferences at the end of life. Telehealth. So, even though the use of telehealth medicine is less prevalent than earlier in the pandemic, it is definitely still being used by providers to deliver care, and we all know is here to stay. So providers should be aware that telehealth medicine has benefits and drawbacks for people with disabilities. We're going to review some of both the drawbacks and the benefits, but we'll start with benefits. Telehealth appointments allow patients with disabilities to remain in their comfortable, familiar home environment. Additionally, they don't have to arrange for transportation or rely on options like paratransit or the city bus, which we know can be very unreliable. So removing these transportation obstacles often helps patients keep their scheduled appointments. Telehealth appointments can also work well if the patient and doctor already have an established relationship and rapport. Communication might be different during these appointments, but there should be less of a learning curve with a known provider. In addition, clinicians can see patients outside of the clinical environment and gain a glimpse into their individual living situations and support systems at home. These appointments can also help patients, supporters, and clinicians build new technological and communication skills and confidence. Along with the benefits, there are also many drawbacks of telehealth appointments. So we're going to list some of these drawbacks and provide some potential solutions. And though the solutions may not be reasonable or appropriate for all situations, hopefully they'll help you think of how to best work with patients to find a solution outside the virtual box. Not everyone has access to reliable broadband, and this can make using the internet for a telehealth appointment difficult. Sometimes technical problems can add another challenging aspect. So phone appointments may be more accessible, but they can lack some of the benefits of a larger screen and keyboard or a reliable internet service. There are many different video conferencing tools like Zoom, Skype, Google Meets, and then some providers have their own platforms. Each tool has different features and different ways of accomplishing desired tasks. But remember that these tools may be unfamiliar to the patient. So medical office staff should be ready to provide tech support or even a practice session before a telehealth appointment. Certain medical and consent forms can be harder to complete online. Patients with disabilities may benefit from paperwork being sent by email or post before the appointment, so it's important to check in with them prior to having these documents completed. And as we all know, doctors can run behind schedule, even in the hybrid world of virtual and in-person appointments. So it's important that providers be aware if a patient has a hard time waiting for an appointment to begin, and then have a medical assistant call or text the patient when they are ready. As Melissa discussed at the beginning of the presentation, some people with disabilities bring supporters to appointments. Many persons with developmental disabilities benefit from support to overcome barriers to accessing and navigating the healthcare system. In 2003, the ARC San Francisco noted that limited access to healthcare meant that persons with developmental disabilities were unable to safely age in place. They were often moved from their long-term homes and away from their community of friends to receive higher levels of care. These moves had devastating impacts on the individuals, removing people from the homes and communities that they had known for decades. So to combat this issue, the ARC created a health advocacy program offering health case management for adults with developmental disabilities. The program successfully supported persons aged 45 and up in connecting with providers, obtaining age-appropriate screenings, and to having a better understanding of medical directives. Over time, our program has grown to serve adults aged 18 and up due to lifelong health needs and ongoing access barriers. And as of today, we serve approximately 130 adults with developmental disabilities. The ARC Health Advocate acts as the bridge between the patient and the provider, helping to facilitate better outcomes through accurate history, supported communication, and follow-through. And while not every patient will have access to a professional or informal health advocate, providers can use the same strengths-based and person-centered approach as the health advocates with their patients and care supporters to foster positive and collaborative patient-provider relations. So providers can use their voices as tools to speak with and not for their patients, allowing for the space and time that the patient needs to be able to ask questions and express concerns and not finishing thoughts or sentences for them. Promoting patients to actively participate in their health, remembering that patients, and secondly, their care supporters, should be consulted when it comes to giving medical directives. Asking what is reasonable and attainable will be more likely to lead to successful outcomes. Supporting navigating access to healthcare, especially when making referrals for tests and to specialists, can be particularly important. Providers shouldn't assume that patients fully understand directives simply because they are stating that they do. Ensuring understanding of next steps and any additional planning that might be needed for the patient to succeed can be incredibly helpful. For example, if a patient is being sent to a different location to see a provider, asking if the patient has transportation to get to that location. It's also important to partner with the patient and their care supporters to enhance understanding of the care plan. Similar to the point above, providers can team up with patients to make directives much more accessible. For example, instead of directing a patient to exercise 20 minutes a day, the provider can support the patient in figuring out how they can achieve that goal. They can ask the patient to identify preferred activity and transform that into an achievable plan. If the patient likes to dance, the provider can ask them to dance to 3 or 4 of their favorite songs in a row every day. Advocating for access to and continuity of care is important because patients with developmental disabilities may have multiple health issues that are addressed by many providers, not always within the same healthcare system. This is especially true when patients are receiving psychiatric services. Communication between these team members is critical to ensure providers have important updates and are not acting at cross purposes. And all providers can be teachers by facilitating and modeling communication with colleagues. For example, if a provider is speaking with a colleague about a shared patient, they can share the patient's preferred communication method or the role of that patient's care supporter with the other provider. And finally, connecting patients with tools, services, and resources. And it's really exciting. I have to throw in here to learn about some of those 2 health plan of San Mateo pages that just went live because they seem really wonderful and applicable here. So when a patient brings up an issue that falls outside of the provider's expertise, they shouldn't assume that the patient is aware of or has access to resources to address that need. An example would be if a patient brings up that they're having a housing crisis. Ask the patient if they have a case manager, or refer to an office or agency social worker, or ask them to identify someone in their life who can assist them. So we've just given you a lot of tips and tools, and now we'd like to show you what an inclusive patient-partnered healthcare looks like in action with this short clip we have about Gabby. And this was filmed a couple years ago, so this is why nobody's wearing masks, just to let everyone know.
I was born with spina bifida. I've had to deal with a lot of surgeries that has to do with it. Having to decide myself, it was really hard. But now that I have a lot of people that help me make decisions, it's a lot easier on me.
Good morning.
Good morning.
How are you?
Fine, thank you.
Gabby's team consists of Gabby and her mom as the sort of central nucleus, and then Mark, who is the health advocate from the ARC, and then I'm her primary care provider. Well, tell me what's been happening in the past couple of months.
We talk about what's going on, and we finally make a decision together.
Hello, Gabby, how are you?
This year has been particularly tough. Gabby was hospitalized for many months, required several surgeries. The decision making around this was to help see what the benefit of having these procedures done and what was the risk, and also trying to focus on kind of the light at the end of the tunnel.
I was so scared of having eye surgery. When the doctor had said that there was a 50-50 chance that it would get better, or as the time passed, it would get worse, at that instant I just shut down because I did not want to lose my eyesight.
Talking about risks to the surgery, benefits, at the beginning she was only thinking about the dangers of it.
We finally came to a decision just talking about it. I am so happy that I did decide to have my surgery. Before, I would see double and I would have blurry vision. And ever since the surgery, none of it has happened. Mark did show the doctors who I really was, that I could speak up for myself. And now to have people look at me like I want them to look at me. It just feels great.
Okay, that's it for our presentation. So, Taylor, is it time to take questions, or do you want to go back to your 2 questions?
No, we can start off with any questions that they have for you guys, and if no one has questions, I sure have a few, so take it away.
Yeah, my name is Hadi Kusnodi Harjo, and I have a comment a little bit about the telehealth, because right now we could see, I'm from behavior side, behavior mental health side. Right now we could see client because of PHE. That's why we could see a client via telehealth. But as we know, PHE, got extended and it will end at one point. And there is a lot of, proposed solution or law, they're trying to make and still pending. And there is no movement since 2020 on the behavior side of it. So the statement that says, oh, the telehealth here will stay, not really. I mean, there is a few of my current client who, basically cannot immobile and get benefit of this telehealth. That make me also worried, because once it got ended, it will be hard for them also to continue.
Yeah, I mean, I think my feeling is that, and again, not an expert on how this is all going to play out policy wise, but I mean, just I always think of it from the financial savings that I think for providers and the ability to see more patients because of that kind of seamless patient to patient. But there is no doubt, to your point, that it does make accessing healthcare for a lot of people with disabilities much easier. And so to take away that option is going to be really detrimental, because I do think there are individuals who have received better healthcare, or at least more consistent healthcare, because of the telehealth.
Thank you.
I was curious, Jennifer, what the process looks like for members to be connected to a health, or for people to be connected to a health advocate, if you're currently still enrolling people in the program, and like how, if providers are interested, they can learn more about getting a member connected.
Thanks for asking. So we are a vendor of Golden Gate Regional Center, and Golden Gate Regional Center covers San Mateo County as well as San Francisco and Marin counties. So usually how folks come to us is that we'll have a regional center case manager reach out to us and say they have a participant who they think would benefit from the service. However, because a lot of other, especially providers within San Francisco, we have much bigger presence in San Francisco. And because of that, sometimes we'll have other agencies reach out to us and say, hey, I know somebody who could benefit from your program. Because we're vendorized by the regional center, the referral has to come through them because they pay us. But we have a wait list currently, but we do continue to accept participants. But if anybody has any questions, because sometimes, especially with the regional centers, they have a lot of new case managers coming in. The case managers might not be familiar. So if any providers have any questions about how the program works and how to get perhaps somebody they think could benefit from the service into the program, they're more than welcome to reach out to me, and I'm happy to talk through it further.
Thank you, that's helpful. And then I was also curious, either directed to Jennifer or to you, Melissa, as I know I mentioned there, we do have a large disparity in our members with developmental disabilities, particularly getting access and completing cervical and breast cancer screenings. So I was curious, just in your experience, I know both of you have worked extensively within this population, if you had any insights or learnings about facilitating those conversations about screenings and like what works and what hasn't worked in the past.
You want to take that, Melissa?
Sure, my husband Owen is going to translate for me.
I think it's important to train providers in that context.
I think it's important to treat providers and medical. Train providers. Train providers and medical techs how to interact with people with disabilities.
Yeah. And difficult, but if you work with the patient in that kids, the support, if you use the procedure.
And sometimes the physical aspects are a little difficult, but if you work with the patients and their support people, you can usually find a way.
Yeah, I totally agree, Melissa. Just to piggyback on that, I mean, I think probably the idea that nothing needs to happen immediately, like there might just be a long runway into the process, right? Introducing the idea, explaining what the procedure is like, what to expect, showing instruments, finding out what accommodations might be needed, for, like Melissa stated earlier about like getting up on the table, or, mammograms, for all women know, can be very challenging, just, how that, and recognizing that, and I've done this myself as a health advocate, that there may need to be a supporter in the room for the mammogram just to help the person, hold their arm properly so they can get a good test outcome. So just taking all that into consideration, and it just might be a longer runway and take more planning than just saying, here's a referral, go get your mammogram.
Thank you, that's very helpful. Does anyone else have any questions for Jennifer or Melissa?
This is Jennifer Stork. I was wondering just how many providers you think are actually prepared or have already integrated service enhancements for disability patients, or is everybody sort of novice?
It's a spectrum, I think. We work closely with UCSF, and actually the ARC is partnering with UCSF right now and Golden Gate Regional Center to look at the Mount Zion campus and bring in and speak with patients with disabilities and their care supporters on what barriers they face to access at that campus and how can those barriers be overcome. And I think of UCSF as it's such a great hospital. We have a lot of folks we take a lot of our folks to their healthcare system, but even they are still working on making things more accessible. So I think we have a long way to go. I think people are starting to recognize that this is a need, but I do think you're still seeing a lot of these accommodations only like in specialized clinics here and there, not just like in general practices.
I thought people have a hard time with it one time.
Also, a lot of people with disabilities have trouble with the ER because it's a stressful situation and it's a one-time visit, and you usually see a new doctor that doesn't have any background.
I have a question. I'm wondering, especially, this is especially relevant, I think, to some of our solo, smaller practice providers that aren't affiliated with the large groups, and so therefore don't have, the resources and the connections that those large group affiliations might bring in terms of really getting on board to the kind of social model of disability that we're talking about. I think that. And I've heard actually from some of our providers that they went through a medical education, to no one's surprise, that was rooted almost exclusively in the medical model of disability. So I'm wondering if you have any advice to them, if they're interested in reframing some of that clinical training into the type of care that you're talking about that's more aligned with these progressive frameworks. Anything structured, right? Like continuing education, a reading list, structured training opportunities that you're aware of?
Melissa, you want to take it or me?
So there's a really good documentary out called Crip Camp that gives a good overview of the history of disability rights. I think I would start there. And I said the and I should promote the Office of Developmental Primary Care's website at UCSF that has a lot of resources for doctors.
Yeah, that's a great website, and I think we have a link in our sources for that. It does have it has a lot of resources for providers and for self-advocates. So it's a really wonderful resource, and it's I know Melissa's done a lot of work for them, and it's spearheaded by Dr. Clarissa Kripke at UCSF, and it's a really great starting point for providers and really easy to access. So that would be a good place to start.
Thank you.
Okay, well, I guess that brings us to kind of the more broader questions. I was curious if anyone had any thoughts or comments about how HPSM can better support our providers with providing resources or guides or any other programming ideas. We're always open to listening to new ideas for different programs. So if anyone has any comments, I'd love to hear them as well.
Is any identifier on member lists there? Like, you have patient A, B, C, and C has, a specific disability, and please use the advocate or something like that. I mean, I have no idea, but I'm thinking that the eligibility list is where we often start with our patients.
That's a really great question, Jennifer, and we certainly don't do it in a disaggregated way that would be useful in the way that you're talking about. We do currently offer in the active engagement reports that our primary care providers get, so I know that's not relevant to everybody on the call. We do offer them a report that has a member aid code for every one of their assigned members. And so, of course, aid code, it really collapses quite a few different types of disabilities into larger buckets that may not, like I said, be relevant to types of modifications to care practices or things like that. But I think it's a great point that we should take back and think about how we can push out better data like that to providers.
But what you're saying is there's already a member aid code that sort of highlights someone with a disability, like SPD or something like that. Okay, so maybe that's
Yeah,
a sort of an education piece more than anything else.
Absolutely, yeah. So I can send you a follow-up email on that, Jennifer, that has that mapping of aid codes in the active engagement report.
Thank you.
Yeah, there's also, speaking of aid codes, there's now on the provider side, so the provider page for older adults and persons with disabilities, there's a list there of all the different aid codes of what we consider to be person with disabilities or older adults when we're doing our analysis. It also has the whole list of the different aid codes. It's not perfect. Using aid codes is not perfect by any means, and we definitely get more rich data internally about who goes to GGRC or who uses other services that might indicate that they have a disability. And so we can definitely do a better job about how we get that information from like where we have it to get into providers to something that's more actionable. So that's a great point. Okay, well, if no one has any other questions, this has been a lovely meeting today, and thank you so much, Jennifer and Melissa, as well as Patricia, for kind of joining us today and helping facilitate this wonderful conversation. All of the PowerPoints, as well as the links that Jennifer and Melissa mentioned, and health tips pages will be kind of compiled and then sent out following the completion, as well as the recording of this meeting. So if you have any other providers that you know of that you think could benefit, the recording will also be available in the future. So thank you all again for coming. I think this has been really meaningful, at least to me, and I hope everyone has a good rest of your day.
Thank you.
Thank you so much.
Bye-bye.
Yeah,